do we have anybody online?
Yes.
Okay.
People are joining in. If you look on the right side of the participants,
oh, yeah,
you can see the attendees. So just give them some time.
Okay, welcome, guys. In the meantime, I would like to know if you can hear me. And where are you from? Where are you at? I would like to see in the chat box. Are you able to send a message, guys? Yeah, loud and clear. That's AV. Aditi from Nairobi. Welcome. So far, we have 15. Victor Mtua.
Bwana, wewe unakaribisha watu aje?
Welcome, guys. Welcome, everybody. Okay. So, Irene, I can see you right there. So welcome for this revision psychiatry revision lecture. It's gonna be a very interactive session for us, and I want to thank Dr. Judy Gichoya for co-hosting with me this session. And we're gonna go through PowerPoints, and guys, I'd like you to post your questions. I'm gonna ask a lot of questions and answers. I would like you to answer them. Post your answers on the chat box. And then let's go from there. Let me know how much knowledge you have. Dr. Gichoya, do you wanna say a shout out to the people?
Hello, this is truly out of my comfort zone because I'm not a psychiatrist. I'm an interventional radiologist, but I look forward to learning something here. I'm just a tech person really for this. And we will use some polling to help with the questions. You can ask in the Q&A. I'm just sort of trying to make sure that we make this good. Please give feedback to Walter. I know he wants to keep doing this. We know he's just over a month starting psych, and so you know, I think we can all learn from each other, and please give feedback. Thank you so much for joining.
Thank you, Dr. Gichoya. So I hope all of you can see my shared screen.
Yes, Doc. I'm pretty sure they can see it, yeah.
Okay, so I know most of you have posted where you are, the location where you are from. We like to know what you do, what you're preparing for. If you're preparing for the USMLE exams, we'd like to know that. This is gonna be a very interactive session, so I like to see what your knowledge is, and I like to learn from you at the same time. I'm going to mix psychiatry with some relevant information, including pharmacology from any other field that you might be interested in. So remember, basically today we are doing a revision. We are not preparing any protocols today for any kind of treatment of patients. So it's more of a revision time we're gonna be having. So I'm gonna start with a very simple question here today, just to open up this session. So this is a patient, and prior to initiating pharmacotherapy and during maintenance treatment, which of the following screening tests is correctly matched to clinical picture? So patient 1, check potassium levels in a 30-year-old man being started on carbamazepine. Patient 2, CBC for a 28-year-old being treated with escitalopram. Then BUN and creatinine for a 60-year-old man on bupropion. You do an echo on 32-year-old man being started on nortriptyline. Follow-up CBC for an 18-year-old with bipolar disorder on carbamazepine. So which one do you think is correct? Which one should you do as a psychiatrist? I can't, okay. Judy, I cannot see. Thank you for that. So can you guys go for it? And don't follow what people say. Just
We'll keep this open for 1 minute. We have
okay.
20 more seconds. Hopefully it's not hovering too much between the questions.
So majority of you.
Wait for people to vote. 7 of 25 have voted.
Okay. Thank you, Judy. Keep me on check. I like that.
15 seconds, closing up. Okay, ending the poll with 38% who have voted.
Okay, thank you so much. So I'd like to encourage you to go ahead and read these questions and answer them. And I see 40% chose E, and majority of you, I mean, almost 60% chose B, C, or D. So potassium level, so first of all, you want to identify which drugs you want to test, you want to do labs for. Escitalopram, bupropion, no, mostly we don't do any labs for those two. So B and C are not correct at the moment. Nortriptyline, we don't do an echo. Remember, an echo is for the structure of the heart. Maybe we can do an ECG, but usually we don't do an ECG on patients who are on TCAs. So carbamazepine is, sorry, we don't do an echo for patients who are on TCAs, and usually we don't do ECGs unless we're thinking of something, arrhythmia going on because of the side effects of nortriptyline. And you see, these are patients that are just starting the medications. So that's the other thing you should underline. So let's look at carbamazepine. There are three side effects you expect to happen when you start carbamazepine. And that should be hyponatremia. The second thing you expect is agranulocytosis. Apart from carbamazepine, also clonazepam is another drug that can give you agranulocytosis. So you want to check the WBCs. It does not affect the potassium levels. So I'm okay that nobody chose that. So E tends to be the correct answer. So I'm going to talk more about carbamazepine and how we use it in psychiatry. So these are basically what I just talked about. So sodium levels, you want to look for leukopenia. Rarely does carbamazepine cause aplastic anemia. So when we initiate carbamazepine, we do the first 3 weeks, we check tegretol levels. The next 6 weeks, we check tegretol levels. Then we check again at 9 weeks. So if that is not, usually we do, if you are not able to see the patient within 3 weeks, you want to do it every month, the first 3 months. Then from there, you can skip to 6 months according to how the patient is doing. So also before you give carbamazepine, check the pregnancy test, do your CBC and LFTs. You know, carbamazepine is metabolized in the liver. And also you worried about NTDs. Okay. So a patient who has been stable on carbamazepine for 6 months relapses despite the fact that he is drug compliant. The patient tells you that since he started the medication, he has not had mania disorders for 6 months. He's worried. I can't see these in my pictures right now. And we'd like to know why he is relapsing. So we're still talking about carbamazepine, and the indication for carbamazepine actually for bipolar disorder is a rapid cycling bipolar disorder. As we keep going, I'll tell you what rapid cycling bipolar disorder means. So what is the best next step for this patient? So it's good for you to know whether this patient is taking any medication, because initially you see this patient has been stable for the last 6 months, no relapses. Then all of a sudden the patient, who is very compliant, starts having the episodes going on. So just find out, is the patient having any medications? Is the patient taking new medications? So if I say that, I'm just thinking about medications that can alter the metabolism of carbamazepine. So is there any substance use disorder? If you're using alcohol, if you're using tobacco smoking, most likely they might be inducers of tegretol levels. You want to check the tegretol levels. So you go ahead and check your tegretol levels, and you realize that the patient has 2 micrograms per mil. You don't have to know this for the USMLE exams. Basically, the normal range is usually between 4 and 12. So in the first 3, 6, and 9 weeks, the tegretol goal level was around 6. But currently we see it as 2 micrograms. What do you think is going on? Can you chart somewhere? Can somebody tell me what they think is going on so far?
This one, we won't use a poll, we'll just use the chat function.
Yes, just using the chart.
And I think you should be able to post anonymously. So if you...
Yeah, there's nobody judging you on this. We're just learning, we just, you know. So Bernard says inducers. Who else? Who else? 2 more. I just need 2 more.
Okay. So Akshay says its metabolism is induced. AV asked, is in carbamazepine an inducer itself?
Okay.
Anonymous attendee said not compliant on medicine.
Yep.
Monali said could the I don't have to mention the name, but on the chat you can see your name. Could the patient be taking OCPs? And Victor, and I'm assuming Monali you mean oral contraceptives? And
yeah.
Victor, an issue with liver and enzymes. Someone else, anonymous, said not compliant on medicines.
Okay, thank you so much. I like the thought process. And at this point, so there's obviously decrease of tegretol levels. So I'm gonna go to the next point, next slide. So tegretol basically auto-induces its own metabolism. So the reason why we check tegretol levels the first 3 weeks, 6 weeks, or the first month, second month, and third month is to just make sure that the tegretol levels are almost constant. So if you see the tegretol levels going down, this is a very special characteristics of tegretol, that it's one of the few drugs that actually tries to kill themselves, like auto-metabolize themselves. So, but the reason why we were asking about other medication is that we wanted, remember this patient said they are compliant, and usually if you see an exam in USMLE exams that shows you like a patient is compliant, just believe them, they are compliant. Just try to look at other things. So this table is like $1 million table right there, or $250,000, whichever. You need to know the CYP 415 users. And if the patient, you know, is a bipolar, he might be using some substances. Again, if initially the patient said he's not using any substance, is not on any new medication, so we're thinking of carbamazepine. Carbamazepine itself, it's an inducer. So this is only applicable when you're using other drugs. But the quality that I just mentioned in the previous slide is that carbamazepine is an auto-inducer by itself. So it's good for you to really know this table: barbiturates, phenytoin, and phenobarbital. All of them will be in that kind of CYP 450 inducers and rifampin. So St. John's wort, most people use it. We don't prescribe that medication. What is it for? So usually St. John's wort, because I don't want to spend time, if you can type in, that's okay, but I'll keep talking. It's usually used for depression. It's over-the-counter medication that you can get, and it's usually an inducer. So the moment you see inducers being used, especially if you're on OCPs, if you're on warfarin, you want to monitor that. And I'll give you another question maybe to look at that in details. So for me as a psychiatrist, I'm concerned that the SSRIs are usually inhibitors. So we can go from there. So the indications for carbamazepine basically is for a rapidly cycling bipolar disorder. Who knows what this means? Rapidly cycling bipolar disorder. And we also use it for neuralgia. Which type of neuralgia? Usually trigeminal neuralgia, that's what we use it for. And we use it for seizure disorders. And the mechanism of action is basically blocks the sodium channels. And so rapid cycling disorder, anybody got anything from the chart? So, no comment?
No.
I'm not able to see actually from my side. It's okay. So rapidly cycling bipolar disorder is those patients who have at least four episodes of mania in a year. So that's a lot. You can think about every 3 months you have a rapid cycling disorder, mania cases, and that's a lot for one patient to have. So usually carbamazepine has been shown to really help in this kind of patients. Okay, so this is another kind of question now related to, and I think this is the last question on carbamazepine. 23-year-old female sexually active patient on OCPs diagnosed with rapid cycling disorder, with substance use disorder, hypertension, and borderline personality disorder was recently started on carbamazepine. We did a DBT and amlodipine. Which of the following should be the best next step in the management of this patient? This is a poll question. What do you think? What's going on? So as you keep thinking about it, is a patient sexually active on OCPs? Do you mind giving us the poll?
Yes, coming up in like 2 seconds.
Okay. So has a substance use disorder now, is a rapid cycler, and has a borderline personality disorder. So what is the best next step for this, for the management of this patient? What is your worry at this point? So should you increase your carbamazepine? Should you go ahead and decrease your carbamazepine dose? Should you increase your OCP dose? Should you change to IUD, intrauterine devices? Should you perform an hysterectomy to this patient? Just get the uterus out of the way. Okay. Should you perform serial pregnancy tests just to make sure she doesn't get pregnant somewhere? You just do serial pregnancy tests. Or should you continue with the current OCP? So this question wants to look at what are you worried about actually? What are you thinking about?
So we have 6 people voting.
Okay.
We have 30 more seconds.
I encourage all of you to try, just throw it in there.
But then no one can see what you vote. We only see
No, nobody can see what you voted. I don't know who is voting what. So it's just a session, a learning session, just to see what you're thinking. And I like when I see diversity, when people think differently.
Okay, closing in 5 seconds. We have 20 people voted, and poll is closed.
Thank you so much. So 53% chose to change to IUD, intrauterine device. So I just constructed this question for you guys, and I think it's something you want to think about. This is a rapid cycling bipolar disorder patient who is using substance use. Most of the time, these patients, whenever they use substance, they forget about their medications. They don't want to take their medications, whether they are on carbamazepine, lithium, whatever medication they are using, they don't want to use them. Whether they are on oral contraceptives, they don't want to use them during that time. And during those episodes, they are usually they have hypersexuality going on. And, so you want to think about their reproductive. Are they ready to get pregnant? So if you do serial pregnancy tests, so the patient is already pregnant, maybe this is an unwanted pregnancy, so that one tends not to be the correct answer. Maybe if the answer was you do an initial pregnancy test and then you do another thing, of course you have to intervene. So continue the current OCP dosage. Yes, you can continue with that, but nobody chose that one, so I don't want to talk about that. You don't want to do a hysterectomy to someone unless they really want to. And this is a 23-year-old and they might be going through a mental health problem. You don't want to do that.
And
so you want to,
it's always the wrong answer to choose the most invasive.
Yes.
Be very careful when for purposes of testing,
Yes.
When you're doing something extreme, think twice.
Thank you for that. So if you, I like the thought around 4 of you chose increased OCP dose. That's a good way of thinking about it, but especially if you're thinking about carbamazepine that we just talked about. But maybe initially you need, if you're thinking of carbamazepine reducing the OCP dose because it's an inducer, maybe you should check the levels first before even increase, because you might be increasing something that is within normal level. But at the same time, there's a comorbidity with the bipolar disorder now and substance use. That means this patient is most likely not going to take even the increased dose. So decreasing carbamazepine, I don't know. If you decrease carbamazepine, what about the bipolar disorder? Are you gonna be treating on a low dose? So that's the question you need to answer. Increase the carbamazepine dosage. 3 of you said that if you increase the dose, most likely it's gonna decrease OCP levels. Most likely not going to take care of this patient's pregnancy. So the correct answer looks like to be D, change to IUD. But if I want to make that answer to be even better, so you do a pregnancy test first, then the next thing you want to do, you want to change to an IUD, intrauterine device, because that's more safer. Whether they have the mania episodes or not, they're going to be safe. So we're going to move to the next slide.
Well, I think there's a good comment from Jimenez, who said interaction with OCPs, decrease effect, and pregnancy, and also Bernard, who said that there's increased teratogenicity effect, which is why the pregnancy is important.
Yes, that's a great point.
To make comments.
Actually, I don't know why I'm not able to see those comments. Let me just try. It's okay. Whenever you see those points, Dr. Judy, just please say something about it, and I'll be happy to listen. So basically, let's get out of those hard terms of psychiatry. Let's look at the basic things. And a 45-year-old lady presents with misperceptions of actual sensory inputs. Which of the following is the correct? So the thing is misperceptions of actual sensory inputs. Any poll for that? Quick one. Can we do 30 seconds, please, for this?
Okay.
Just 30 seconds, quick ones. Most of my PowerPoint, it's just questions to see your knowledge, and it's for your own feedback, so that you just, you just think through what you're doing wrong, because most of the time the USMLEs will throw in something there. And this will be just 30 seconds because it's just almost straightforward, but it's not always straightforward. So this is gonna help you personally. So it's not for me, it's for you. I think most of you are doing this, like we have 15 people doing the poll, almost 20. We have 6 seconds to go. If Judy, you allow me, within the next 3 seconds, we stop. Okay. Thank you. So 52% of you chose C, which is correct. So another good percentage of you chose A. So this is what you should think about. So there are some things that are imaginary, and there are some things that have some sensory input. So illusions, basically, there must be a stimuli, something you see. For example, so if this person sees, I always joke around with this, like when men go drink alcohol, they see ladies out there, they don't like them, then all of a sudden they start liking them. I think it's a form of an illusion. That's my joke. But so the thing is, maybe you look at some shadows, that's a sensory stimuli, and your interpretation is different of those shadows, what they are. So that's an illusion. So we're going to break down and look at, for example, that picture. If you look at that picture and just look at one, you think that they are moving around, you see? So that is an illusion. If you have watched illusionists, and if you watch YouTube or somewhere, you see illusionists doing some funny stuff, you think they're doing something. It's just an illusion, just a perception. They just want to see how they can trick you with this, and you see it differently. For example, these pictures, you see them moving, but actually they are not. Okay. So a couple comes to your office. The wife says that the husband has become convinced that she is cheating on him. He has been following her, smelling her clothing, going through her past. Is not functional at his environment now, because this guy is really thinking that there must be a problem and with the wife, and that's not true. So what do you think this is going on? So this is a delusion. So that's where the delusion comes in, a false belief. So if you classify delusions, you can talk about them as bizarre or non-bizarre. So if I say this is not a bizarre delusion, by the way, this is a non-bizarre delusion, because it's possible the wife can, can cheat on this husband. So that's a non-bizarre delusion. But when it's bizarre, it's something that they believe that cannot happen. So what about a patient comes to you, tells you that they feel like an outsider observer of themselves? They see themselves doing something outside themselves, like their mirror image is doing something. So they feel detached from themselves. They feel, so basically this is a form of depersonalization. So those are the terms you need to know for USMLE and for the future. This is depersonalization. And if we have unreality, whereby you feel like the environment, the surrounding. So the personalization is personal, like you feel from inside that you're detached. But the realization is basically whereby you see the surrounding is unreal, So the objects might not look real the way I see objects. You might see things looking like lifeless, dreamlike, of visually distorted. So that is, if you perceiving the environment as unreal, that looks like derealization. That should be derealization. So patient comes, you are in emergency department, and somebody is brought to you who has been wandering to new places, and he has assumed new identity. But when you look at the ID card that he's carrying, he has another identity. He has forgotten everything. He doesn't know how he found himself even in the emergency room. So what do you think this is? So I don't know how to say that name correctly, but it's dissociative. Is it fugue or fugue? I don't know. I don't know how to say. I've tried to say. Let me just type in maybe somewhere. Dr. Judy, are you able to say that name? Do you remember?
No.
Okay.
Fugu. But you will know when you see it on the exam.
Yeah,
I think it must be a French.
Yeah, it's Fugue. So I don't know how to say it. If somebody can type that in for me, I'm not able to see your comments, guys. I will look at the end of this, and we can have a question answer thing at the end, any additions or something like that. But it's dissociative fugue, something like that. So in the exam, like the USMLE body exams, they want to know if you can really evaluate a patient, and they want to know what will you ask or how will you evaluate attention and concentration. How do you test for
Walter, before
attention and
you,
concentration?
you go to sort of a new theme, there's a question. Please explain depersonalization and derealization once again.
Okay, yeah, I'll go back there. So the personalization, as the word goes, it's a personal thing, something I feel. Maybe you watch yourself, outside yourself, you're detached, like you can describe yourself outside you as a person. Like you see yourself as an outside observer, like how you behave. So you are the person, and it's like you seeing another person who is Walter out there doing some things differently. That is personal, like as the word depersonalization goes. So the realization is the environment, is the surrounding. So you see the surrounding as unreal, you know? You see, like maybe like now, I even look through my window, I see trees, I see wind moving, and somebody will tell you that everything they see is lifeless. Like the surrounding doesn't look real. It's not exactly what other people will be seeing. So that's basically environment and person, how I feel about myself, and how I look at myself as an outside observer. That is the personalization. The realization is more of the environment. Okay. So attention and concentration, basically how you test for this. If you have already not, I'll encourage you to post. Anytime you see me asking a question, just post something in explanation. So how do you test for attention and concentration, for example? Already some words. Judy, can you see anything? I should do better to see your comments, guys. But so
Yeah.
usually you'd use a series, 7 series, whereby that's I think there are many other ways you can do it, but usually, and for the USMLE and for the most body exams, I'm doing the APA psychiatry. They recommend these two, and so you use a series of 7s, whereby you tell the patient, can you subtract 7 from 100? You know, so they can do it like 3, 4, 5 times usually, and you want to see how they are attentive, because if you tell some, you have to be attentive and you have to concentrate when you're doing those. So you can tell them to spell that word, world, and from maybe front backwards or whichever way you want to. So you have to concentrate when you're doing this, attention and concentration. So attention and concentration is not like when you want to ask somebody for memory. For example, if I want to ask somebody for a short-term kind of, I want to check the short-term memory. Basically, I will tell the patient 3 things, objects that are not related. For example, I tell them a penny, you know, the small coin, and I'll tell them an apple and maybe a watch. So that's short-term memory, and that's how you test for that. So those are 2 different things, and some people tend to confuse them. So waxing and waning concentration, worse at night, disorientation, impaired cognition, altered sleep cycle. Like this patient comes in, sleeps more during the day, but wakes up in the evenings and at night. They have perceptual disorders. We talked about misperception in the previous PowerPoint. So they might have some perceptual disorders. So what do you think is going on? Give you 2 seconds, 3 seconds to post that. So we're dealing with delirium, basically. That's delirium. Delirium happens mostly to older people, maybe 65 years, and most of them, they might be having infections. So infections is big. They might be under some influence of benzodiazepines, anticholinergics, like diphenhydramine. Alcohol withdrawal is big with delirium. And you know, alcohol withdrawal will give you delirium tremens. And, and there's a different way of just managing these things. So I want to go ahead and tell you, investigation is wide. It depends on what you suspect. So I don't want to really go into details. So basically, if you're doing USMLE step 2 CK, they want to ask you what is the best next step. So first of all, you have to identify its delirium. And second, you have to look at what these patients are taking. If they're on the BZs, you want to stop. If they have infections, you want to do lab work. If you think they're having infections, and if they give you the virus, of course, you think about infections. And you can do a number of these investigations, depending on what you suspect. So the best thing to do is simplify the medications. If the patient is on a list, a junk of medicines, I've seen patients with 20 different types of medications. Most likely there's a problem with that. Discontinue the BZs, avoid BZs, but there's only one time we do use BZs. Anybody who knows when we'll use BZs in delirium, kind of. So if you have a patient and you suspect it's alcohol withdrawal, usually we use BZs. And I will ask you a few questions about that BZs in the next few minutes. If you chat on the Q&A, I will see that BZs is benzodiazepines. I see, like, I think Bernard is posting on the Q&A, and I can always see those comments. I don't know why I can't see the other ones, but that's okay.
If you need something, could we just use the Q&A portion of it? But I'm monitoring the other one, so let's just use the Q&A.
Okay. Okay. So you need to provide reassurance. You need a one-on-one nursing program kind of going on, and you want to judiciously use antipsychotics for agitation. We use mostly haloperidol. So the other terms that come in when you see sad persons, this is an initial. What do you think about? So usually sad persons is an abbreviation for suicide risk, and usually it's this, you need to know this for the USMLEs. It's usually sex is usually male. That's they're at high risk. What we don't like as psychiatrists is to take care of a patient who goes home and commits suicide. So in psychiatry, you need to know this. So male, more than 65 years old, this for depression. Previous attempt, that tends to be the biggest risk. If you see all this in your exam, and they tell you which one is the biggest risk, previous attempt. If somebody has attempted before, chances are they are going to attempt again. So you see, the other things like ethanol is another risk, rational thinking. You lose the rational thinking kind of thinking, and there's suicide in the family, that's another risk factor. And if you have an organized plan, actually, when we talk about an organized plan, is that one, you have the idea, you have the notion of committing suicide. Two, you have a plan, the intent to do it, and what are you going to use? So if somebody has a gun at home, that's high risk. You want to make sure they don't have a gun. If they're living by themselves, that's another risk, like no support, excuse me. They don't have any support, or they have some sickness. So a 65-year-old who has terminal illness, in pain, is likely to commit suicide because of that. So watch out on those suicide risk factors. I threw in some things you need to know about mania. And when patients have mania, they have distractibility, irritable, grandiose. They have flight of ideas, speedy thoughts or speech, thoughtlessness, not thinking of consequences. So they can indulge in sex, they don't think about any infections, and that's how they kind of live. And they can want to have sex with anyone, if that's. CG caps, we use it for depression, and it's good to know. You don't have to know these initials, actually. So I don't think I explained the CG caps, what it means, but I'm gonna explain it right now. S stands for sleep. So the first thing you want to ask the patient, if they have a problem, when they get to bed, how many hours do they spend? Usually, ideally, it should be less than 30 minutes. So if you're taking more than an hour, maybe you should be. If you take longer and consistently you take longer periods of time to sleep, we want to know how long do you sleep. Most of them will tell you they sleep like 4 hours. And early morning awakening, they wake up very early in the morning. So the other thing is anhedonia. So that's interest for I. So it's lack of interest. So it's basically known as anhedonia in psychiatry. So somebody will tell you, I used to like go fishing, but currently I cannot. The other thing, G is for guilt. They feel guilty about for some reason, or hopeless. You can put hopeless down. The E is for energy levels. They feel their energy levels is low. Poor concentration for C. A is for appetite. You ask them, they have poor appetite. Sometimes they can have very high appetite, like they want to eat everything when they feel depressed. P is for psychomotor agitation, and S is for suicidal risk. So you have to check. And most depressed patients, they have that suicidal risk. So which of the following is not used for the treatment of depression? So guys, Judy, if you get a poll for this, I'll be very happy. Which one is not used for treatment for depression? So we have citalopram is an SSRI, venlafaxine is an SNRI, duloxetine is an SNRI, bupropion, I think it has norepinephrine, dopamine, if I'm not wrong, kind of mode of action. ECT, transcranial magnetic stimulation, deep brain stimulation, esketamine infusion, cognitive behavioral therapy, we have trazodone and light therapy. Do we have a chart for this?
I'm just adding the additional options. Sorry.
Okay. I'm sorry, this is super long. So guys, what do you think? Which one don't we use for depression? Do we use everything for depression?
People are typing on the chat too.
Okay.
So
I can't see the chart. Do you mind?
So G. H. That's what I can say so far. H.
Okay. I think I kind of got the highlights, what you guys are thinking. And
yeah, lots of H. People would have
H and G mostly.
Yeah.
Okay. So citalopram SSRIs, we do use them heavily. Venlafaxine, duloxetine, especially duloxetine, we use it for patients with fibromyalgia, and they come with a lot of pain. They say that we give them because it's an SNRI. Bupropion, we do use it. It's kind of an atypical. ECT, we do use ECT heavily, especially when the other medications are not being able to work. And they do miracles, these ECTs. Transcranial magnetic stimulation, we do transcranial magnetic stimulation. Deep brain stimulation is not typically used for depression. What do we use it for? If you can type in deep brain stimulation, if you guys want to type in, as I keep talking. Esketamine, we do use esketamine. So esketamine is basically a form of anesthetic agent that has been shown to be very good, to be helpful in patients who have a problem with depression. So we do use it for sure. Cognitive behavioral therapy, sometimes we do encourage cognitive behavioral therapy, especially in pregnancy, and we don't want to give them any medications. But sometimes also in pregnancy, we do use ECT. But it's very difficult to convince mothers to use ECT. Trazodone, high dose, yes, we do use trazodone. And one of the side effects of trazodone is priapism. You should remember that for the exams. Light therapy, for something called SAD, seasonal affective disorders, we use light therapy. So some of you might not know about seasonal affective disorder. So some people have, like during winter, they have a problem with depression. And when it's summertime, they get out and there's no more depression. So you give them light therapy kind of thing, and this helps them during the seasonal affective disorder. It has been shown to be very effective. The other thing you should remember is that bupropion can cause seizures, and it's usually contraindicated in eating disorders.
There
Yeah.
are several comments that
Mhm.
deep brain stimulation is used for Parkinson's. And,
Perfect.
and I
I
think
almost
you
forgot
need
that.
to summarize what the answer is.
I summarized the answer. Okay.
Yeah.
So deep brain stimulation, we don't use it for depression. So deep brain stimulation is basically something that is used for Parkinson's, and you want to go deep in the brain to the, I think, substantia nigra around that area. You want to stimulate the brain and just to help in terms of movement and all that. I don't have a lot of experience with deep brain stimulation, but I think in the subsequent lectures, when I get exposed to it, I will comment more about it. But it's good to know. Sometimes the USMLE, they will throw in these things like transcranial magnetic stimulation, and most of you have never seen them. And I will explain a little bit about them in the subsequent slides. So that's TMS. Usually you put it on the left side of the brain, the left frontal. That's where you stimulate for depression. And it has been shown to work, actually. The problem is it's a little bit expensive. It's like you're on a dental chair and you have this stimulation. You can talk to this patient like you're passing some electricity to the brain. Then it goes all the way down to the limbic system. And because of that, you have this person like feeling better, feeling the mood comes back in. And this is one of the things I'm thinking of doing actually, Dr. Judy, interventional psychiatry. This is interventional psychiatry. I think I love it. So this is TMS versus ECT. ECT, you have more electrodes going on and you're gonna shock the patient. And that's just a picture to show you like, those are just to memory for you. Unless you're doing them, I don't think we need to go ahead and talk more about them. So vagus nerve stimulation, it was FDA approved in 2006. And this is usually used for different things. Actually, it's used for headache, it's used for seizures, and it can be used for depression. I don't remember putting this as one of my choices, but it can be used for depression. But the problem is in the US currently, the VNS is not used for depression. They think it's expensive. The insurances don't pay for it. So we don't get many people coming for VNS for depression. So I think you get the point. But mostly I've seen in the neurology clinic, I'm currently in neuro, and I've seen a lot of VNS coming because of headache, because of seizures, intractable seizures, or chronic headaches that have been there and it's not relieved with medication. So that's when we go for the VNS. So guys, in psychiatry, there's comorbidities. I want to talk briefly about drug abuse. It's not, and I want to encourage you to use the chat box. So a patient comes with tremulousness, hypertension, tachycardia, anxiety, psychomotor agitation, has nausea, seizures with hallucination, mostly visual hallucinations, this patient. What do you think is going on right now? Any quick response?
But I found these drugs of abuse very confusing because they're very specific buzzwords. And
Yes.
really, starting
Yes.
from Kenya, I didn't really know them.
This drug of abuse, the way Dr. Gichoya is saying, they very high yield, and you just need to know the buzzwords. You just need to know one. Because, for example, if I tell you hypertension, tachycardia, anxiety, psychomotor agitation, it cuts across. It's like in every kind of substance use, drug abuse. So I'm going to give you buzzwords. For example, hallucinations, that's visual hallucinations. And the other thing is tremulousness with the other things that you see there. So that looks like.
So there are many things. There's formication, DT, amphetamine, cocaine.
Yes,
alcohol withdrawal.
Yes, I'm gonna mention that. Actually, I have a few slides.
I'm just reading the options. Sorry. I'm not trying to say that.
Oh, can you say that again, please? Sorry.
So cocaine, alcohol withdrawal, amphetamine, and delirium tremens, which is alcohol withdrawal.
Yeah, delirium tremens and alcohol withdrawal is the same, and I kind of agree with that. So this is alcohol withdrawal, and usually whenever you say there's delirium tremens, it usually happens, I think 2 days to 4 days, yes. And there's fever, there's autonomic hyperactivity as additional things that you'll get. There's auditory, but usually it's more of visual hallucinations. This is what they get. So the buzzwords are, if you see visual hallucinations and tremulousness, then they can add all the other things like hypertension, all the other things. Delirium is part of it in alcohol. So those are the kind of 3 or 4 things that you're gonna look for: hallucinations, delirium. You're gonna look for tremulousness, and those are the things you're gonna go with alcohol withdrawal. So how do you treat these patients? So we said, whenever you have delirium, you want to avoid BZs, but these are the patients you want to give BZs. On the other side, whenever you want somebody's taking the medications, is taking alcohol, and you want to decrease their alcohol intake, these are the first lines and second line. So for delirium treatment, sorry, for this, let me just emphasize on this. For treatment for delirium tremens, you want to use BZs, and also you wanna, of course, you want to give them vitamin infusion. You wanna hydrate them, whatever other things that are going on, and get them through that phase. But when they're out of that phase and you want to reduce their alcohol intake, you wanna give them naltrexone. Naltrexone is an opioid receptor antagonist. You should remember that. Naltrexone, we really use it. So remember, naltrexone reduces cravings. So we tend to use it sometimes, even in eating disorders, because it's just a craving. Some people want to eat more. I'm talking of obesity. Those people want to eat more. Sometimes you use naltrexone because of the craving. A compressate is another thing that we use as first line, and it modulates glutamate. The other second line that we use is like disulfiram. You should remember this from biochemistry, alcohol dehydrogenase inhibitors, but we don't use it in pregnancy, cardiac diseases, or psychosis. Topiramate is an anticonvulsant, but we do use it for this to reduce cravings too. So with alcohol, you remember the Wernicke-Korsakoff. So I don't want, because I don't want to go more than an hour for this. I want to go within almost an hour there. So I don't want you to chat in. I want to give you the points. Ataxia, confusion, and ocular nystagmus. So you expect these patients to have this kind of gaze pulses with nystagmus, and they have also confusion and ataxia. So how do you treat these patients? You give them vitamins. Which vitamin? So usually, do you remember which vitamin? B3, B2, B1. So B1, that's what you give, thiamine. Basically, you should remember always B1 and thiamine. You should remember those. So always give the vitamin before you give glucose infusion. The other thing is Korsakoff is just confabulations. When you see somebody making up, because they forget, they have amnesia, and they start making up stories. Okay, so and it's reversible in 20%. So another question on drug abuse: increased sympathetic activity, nausea and vomiting, diarrhea and diaphoresis, rhinorrhea, piloerection, and yawning. So those are the buzzwords for me. So what do you think is going on? I'm giving you 2 seconds. You can put something in there.
Opioid withdrawal, some of the answers we're seeing. Opioid withdrawal, another participant.
Any other? Okay. So perfect. This looks like opioid withdrawal. It's perfect. Rhinorrhea, piloerection, yawning, diarrhea. So remember, when you take opioids, they give you constipation. So the reverse now is true. If you stop using these opioids, you have diarrhea. So yawning and piloerection, those kinds look. The other things are neither here or there: nausea, vomiting, cramps, myalgias, arthralgias, restlessness, increased sympathetic activity. They are neither here or there. So you have to remember the buzzwords. So what happens to neonates, neonatal withdrawal? So a mother who has been taking these opioids and throughout pregnancy, and you get a neonate, they present almost the same, but there are some buzzwords that you should remember. So high-pitched cry, tight muscle tone, and yawning and sneezing. You know, yawning, it's coming back again. So poor feeding and sucking, they are neither here or there. If you have meningitis, you'll have poor feeding and sucking. So you have to remember the buzzwords like high-pitched. So if you read like a clinical vignette that has thousands of words in, and you see high-pitched cry, tight muscles, yawning, just go ahead and think about think about, how do you call it? Opiate withdrawal. Next, vertical and horizontal nystagmus. If I see that, straight away I think of something. That's a buzzword. So hypothermia, tachycardia is neither here or there. Ataxia tends to be kind of something you expect, and belligerence. Belligerence is like war zone, like you want to fight, you want to do something like that. So this is typical. If you've seen nystagmus, you're thinking of PCP intoxication. I would like you to go ahead and look at videos on if you have never seen nystagmus. But which anesthetic agent is related with PCP? And we just talked about it. So it's ketamine. So ketamine tends to give you some, if you know about ketamine, and some symptoms are almost related because they have some dissociation that happens when people go through ketamine, dissociative. I don't remember the other word that I can use there, but PCP and ketamine. So patient with euphoria, increased attention span, pupils dilated, hypertension, cardiac arrhythmias. And these people might tell you that pupils dilated, that means most likely this is not an opioid intoxication. They have cardiac arrhythmias, so that's different, and increased attention span. So we haven't experienced that. The other thing, this is not super detailed. The other thing they might tell you is that like these people have staining of the teeth when you do the examination. What do you think that should be? Quick one. Okay, amphetamines. So usually have stained teeth. They can cause dilated cardiomyopathy. I've worked in a drug rehab kind of center before, and I had this patient who has been using amphetamines. You know, he will have all these discolored teeth, and he had I think he had an ejection fraction of like 17. So usually, if you want to do a heart transplant, just I'm throwing this information out there, you don't give heart transplants to people who use substance. That's one of the contraindications. So the only thing you can do is cardiophysiotherapy. So I want you to always remember amphetamines with cardiac problems, with teeth problems, and also they'll have all these kind of pupils dilated, hypertension, and increased attention span. They tend to have that. So, so if you have amphetamine withdrawals, usually you have something called post-use crash. So somebody has been hyper, has been having these attentions, increased attention span, then all of a sudden it's like depressed, has insomnia, is irritable. So these are people who you think of amphetamines withdrawals. What about formication? Formication is like a buzzword. And usually when you have formication, this is a sign that patients come with and tell you that they feel like there's insects crawling on their skin, you know, that's formication. So, and most of the signs are like amphetamine toxicity that we just talked about. Like they have increased attention span, they might have cardiac arrhythmias. And this drug we're talking about actually can cause a myocardial infarction because it has very high vasoconstrictive ability. So I want you to think about cocaine in connection to formication. That's cocaine. And you remember cocaine can give you an MI. So patients who come with an MI, myocardial infarction, you want to think in terms of, are they using any drugs? And one of them is cocaine. And as I told you, cocaine and amphetamine, you want to always relate them whenever you see in the exams and try to distinguish them, especially with formication. So a patient with euphoria, anxiety, paranoia, slow time, social withdrawal, huge appetite, dry mouth, a motivational syndrome. So what do you think? Social withdrawal, thinks that the time is so slow, he thinks like one day is like 48 hours or something like that. And the other thing I didn't mention here, which is a buzzword, is conjunctival injections. So they have this reddening of eyes, and they think about slow time and all that. So what do you think? ISD. Any other? We are almost at the end. I think we have a few more slides to be done. I don't like going above 1 hour. I want to maintain within 1 hour or maybe 1 hour, 10
It's
minutes, and that's
marijuana.
marijuana. Okay. Somebody said LSD.
THC.
Marijuana is another one. Any other?
THC.
THC, same thing as marijuana. Thank you. Whoever said marijuana, I think you're right. So, sorry. I think marijuana, you're right. So if you see conjunctival injections, you see social withdrawals, low time, these people always doubt, like, why are you saying that? They have paranoia kind of thing, and they have dry mouth. They have a huge appetite. If you see people who take marijuana, they can eat a lot of food at a given time, you know? So that's a question they like asking. So the other psychiatric emergencies that I wanted to talk about, I don't know how long, I
We
think I
can
have a
pick up
couple
from
more
here, right?
slides. Sorry?
Because this is a new topic. Do you want to
Yes.
just use maybe 5 or 10 minutes to debrief and see what was helpful for people, and we
Sure.
can move on from psychiatric emergencies. But also, you know, we can have a quick suggestion. Do people want to continue or take a break?
Yes, that's what I think. Because I think I have a couple of more slides. Thank you, Doc, for that. And I don't want to go more than an hour. So if you can put a poll there, we see if we can continue. And if you have any questions that you
There's
want
one
to...
suggestion to continue. There are 2 people saying continue.
Oh,
See at least
that
maybe 5 people.
5 people. Maybe we have more than 10. We 32.
Oh, there are lots of continues. Okay.
Okay. Okay, perfect. So before we go to this topic, do you guys have anything you want to add? I like people adding suggestions because I don't know everything actually. I'm still learning, so it's a process, and this is a collaborative thing that we do together just to make sure you have all this information. And I want to tell you that substance use disorder, it's everywhere. You will find it everywhere in your exams. It will always come. Trust me. This is like, you need to know these buzzwords. You just need to move with them. And even if you just do up to step 3 and forget about them, that's okay. So long as you get where you need, you just get the bridge. It's just a bridge for you. So in summary, if I just look at cocaine, we just talked about cardiac arrhythmias, and also we talked about fornication and MI. If you remember, we talked about amphetamines as almost the same. If you have a withdrawal, you have this post-use crash. That's very important. And I will put these things on YouTube, I believe, and you guys, you can access them anytime. So I don't want to go back there unless you have a question or a comment. Otherwise, I will go to psychiatric emergencies. I don't want to confuse you with the above. Is that okay? So you said continue. So unless there's anything, Judy, there, I cannot see these comments. I feel so bad. I think next time I'll be better in looking at these comments. Okay, I believe silence.
There's a comment about the CIWA score for alcohol withdrawal. Guys, this is just like, we'll debrief. I would just say, let's finish the talk and then debrief what would be better, what people want to see a little bit. And then so that if people want more of this, we can, you know, so opioids is a big crisis in the US right now. So there'll be many questions. You cannot forget this. This is something that you'll have to take care of. And alcoholism.
Yep.
So there are 2 things that we can do. There's practical knowledge about psychiatry, but this is more of gamesmanship for this talk, how to get the gist. And because this is just something we don't, at least when I did my USMLEs, I didn't know, and I struggled with in terms of gamesmanship to know, oh, what should I be thinking about those questions?
Yep. Thank you for that. So I will go to psychiatric emergencies, and you know, any emergency anywhere, you want to know about it. That's something you don't want to miss. And it's big in the exams, any board exams, whether it's the exams for psychiatric that I expect to do in the next 4 years or 3.5 years, whichever. You need to know this. So delirium tremens, we just talked about it. NMS is neuroleptic malignant syndrome, serotonin syndrome, hypertensive crisis, acute dystonia, already threw in some treatment that you use for that, lithium toxicity, and TCA toxicity. So DTs, we mentioned them. So basically it's 2 days, after 2 days, usually. And just if you see something after 24 hours, most likely it's not delirium tremens. So usually use benzodiazepines. And you want to hydrate this patient as much as you can. So a quick question, a patient with delirium tremens with history of liver failure is under your care. Which of the following will be the best BZ to use? This is just like a question you have to know. Most people who take alcohol, you know, metabolism of alcohol takes place in the liver. Initially they have a fatty liver, then they complicate to cirrhosis. So you need to know which kind of medication you want to use. So a quick poll, A, B, and C, D. Can we go with that? Which one do you want to use?
Yes. So I will relaunch that poll.
Yeah.
Okay. Oh, I guess we moved.
Sorry, you're good. So guys, let's do this. Which medication do you want to use? Yes, let's do this. Okay.
Okay.
I think we'll give it 20 more seconds so that we have everybody on board. Okay.
Okay, ending the poll.
End of the poll. Perfect. Thank you, guys. I mean, most of you kind of 50% got it right, and that's so encouraging for me. But it's not like almost 50% did not get it, but that's why I'm here for you. So basically, there's something called out of the liver, OTL. So you can use oxazepam, you can use temazepam, you can use lorazepam. So most of you got it. You don't use chlordiazepoxide because that one is metabolized in the liver, and you'll see some literature telling you like chlordiazepoxide is really good for alcohol. But if you have a problem with the liver, the only three that you can use is OTL, and you should remember that: oxazepam, temazepam, and lorazepam. We usually use C, lorazepam, Ativan. I think the half-life, there's something you need to learn about half-life of this medication. Lorazepam tends to have a shorter half-life. If I'm not wrong, you can correct me on that. But we tend to use that one most of the time. So that's why I see majority of you said C, but those who said A and B, they are still right. And you should remember that. So that's just putting this across to you guys. Okay, then we have neuroleptic malignant syndrome. So if I think about this, neuroleptic malignant syndrome is very, very closely, almost same as serotonin syndrome. There are a few things that I look for me to decide whether I'm on the side of neuroleptic malignant syndrome or not. One of the things that I look for is the rigidity. If you see this buzzword, lead pipe, rigid, you're thinking of NMS. The other things will be there. You'll have clouding of consciousness. Autonomic instability means that your vitals will be up and down, you know, pulse rate will be all the way up to the roof, blood pressure will be high or something like that. You'll have elevated WPC and CPK. So if somebody is so rigid, most likely there will be some problem with the CPK. So those are the kind of investigations, if you think about it, some of the investigations you want to do. So how do you take care of NMS? You want to hold the neuroleptics, you want to hold them, you want to hydrate the patient, use dantrolene or bromocriptine. So, so basically that's what I can say about this, but you need to know the mechanism of action of these drugs, and I don't want to go into details with that at this point. So serotonin syndrome is, I told you, they tend to have that kind of confusion. You always confuse the two. And you see, first of all, whenever you have a clinical vignette, just note for serotonin syndrome, if you see an MAOI plus an SSRI, most likely this is going to be a serotonin syndrome. Most of the time, these patients come to you and they tell you, you know, I'm on selegiline, I'm on citalopram, which we don't do. Usually we don't do that combination as psychiatrists currently. But if you see a clinical vignette, because they put those things there, even if we never do them nowadays, and they tell you, or the patient came in and got a new prescription of ondansetron, got tramadol. The other drugs that you can think about is triptans, like sumatriptan, and if I can remember off my head is I don't remember any other, but ondansetron, tramadol, triptans, and SSRI with MAOIs, all those can really cause serotonin syndrome. So they have clouding of conscious. So altered mental status, same thing like the other one. Fever, just like the other one. Agitation, just like the other one. Tremors, just like the other one. Myoclonus, almost just like the other one. So the thing is, if you have this patient having, there's no lead pipe rigidity as much, and there's diarrhea. So you do realize there's a lot of serotonin receptors throughout the GI. So I tend to, whenever I see there's no lead pipe rigidity and I see somebody commenting about food and timing, we'll talk about it shortly. Thanks, Bernard. So if you see the diarrhea, a lot of serotonin in the GI, ondansetron tends to work in the GI. Tramadol tends to work in the GI. You remember sumatripans, they have 5-HT3. I'm not very sure how I can relate sumatripan to this kind of GI. So if you, I'm just thinking, hyperreflexia will be either in both sides. So, but diarrhea is something that I tend to really tie down with serotonin syndrome. But with the history also, you have to connect the two. Okay, so how do you treat that? So BZs again. So, sorry. So BZs is something you can use. I had a patient recently, actually it's not even a week. So this patient came in with, has been started on SSRI, and this patient has a lot of pain. They thought, okay, fine, you have a lot of pain. We can give you an SNRI. So they gave this patient an SNRI, and the patient comes again, says, you know, I'm a little bit, I have this back pain still, it's not going away. They gave some oxycodone or something, an opiate, it's not tramadol for sure, something. And you know, whenever you give these opiates, they are like, oh my God, you know what? I'm so nauseated. Can I get something? They gave ondansetron, like 4 milligrams or 4 grams. I don't remember the dosage. This patient went ahead and, you know, a few days down the line, I think there's another adjustment that was done. And this patient comes back with all these like altered mental, feels like having diarrhea, feels confused. You check the reflexes, the patient is so hyper-reflex. So the question was, what is the medication? You know, it's an emergency. What are we gonna do? Oh my God, what's going on? So lorazepam, again, you're gonna give BZ, calm down this patient, stop the other medications. Ciproheptadine is used, but I've not seen it being, personally, I don't have experience with it, but this is one of the biggest things that in the USMLE or any board exam, they'll ask you if you remember ciproheptadine. Sorry. So somebody mentioned about tyramine treatment with hypertensive crisis. So those foods can really give you hypertensive crisis and while you're on MOIs. And this is the kind of pathophysiology. You know, psychiatry, people think we don't know a lot of pathophysiology, but once in a while we throw it in there. And so, so you see, if you take a lot of tyramine, they are increased in your circulation for sure. So if they are increased in your circulations, they are going, instead of inhibiting these vesicles, they are gonna release them. And these vesicles, you see right there, they do have noradrenaline. And this is gonna cause hypertensive crisis. So if you see that, stop. First of all, you need to educate this patient on tyramine kind of food, cheese, red wine, I believe. I think there's something I read recently that was really fascinating about these foods. This, I can't remember it offhand, like right away, but they're gonna increase and you're gonna have hypertensive crisis. And these are the patients you're gonna give nitroprusside. You remember nitroprusside, the mechanism of action, you have to know this for step 1. It's a vasodilator for sure. I don't know if it does both vaso and arterial. Maybe you can check that. Phentolamine is an alpha adrenergic antagonist, I believe. So, you know, this is adrenergic kind of response. So giving an adrenergic antagonist can be a good idea for this kind of scenario. So 35-year-old with bipolar disorder, hypertension, and diabetes comes to your clinic with the following signs and symptoms. Nausea, vomiting, slurred speech. I will take slurred speech. Nausea, vomiting is neither here or there. It's always there in everything. Ataxia, incoordination. There's something they're trying to push down. Myoclonus, hyperreflexia, seizures, nephrogenic diabetes insipidus, and with some delirium. What do you think, guys, is going on? Patient cannot remember his medication list. So this is typical. They never remember in exams. Sometimes in real life, they do remember, but sometimes they don't. So what do you think, guys? Anybody else with a comment?
People are typing lithium toxicity.
Okay, perfect. So lithium toxicity, buzzwords, nephrogenic diabetes insipidus. And you have ataxia and incoordination. I tend to take those 2 or 3 together. The other thing that they can cause actually is hypothyroidism. Patient may present with hypothyroidism or thyroid problems. So lithium toxicity is something you really need to know. And sometimes it's good to know the values. I think this is one of those things that I needed to know for the USMLE. If the lithium levels are above 1.5, usually that's not good. They can cause ataxia and incoordination. So that's one thing you need to monitor. You need to monitor lithium levels regular. I'm not 100% sure how regular. Currently, I'm not sure how regular you should monitor this, but I think every 3 months. I don't know if there's anybody who has experience with lithium and how often you do monitor it, because I remember when I was in Kenya before, it really depended on how regular that patient came for checkup. But at the moment, I'll check that protocol right now in the US, like how regular we do use it. So the thing is, stop the medication, hydrate this patient, consider dialysis. That's another option. And if this patient has other problems like thyroid, so the next other best investigations you want to do is you want to check your thyroid function tests. Okay. Acute dystonia is sudden onset of muscle spasms, eyes, tongue, jaw, neck. So usually this happens, like you give the patient a medication today and the next day you see him having spasms in the neck and he wants to stay like that. So what's going on? So this is acute dystonia. It's one of those things that happen almost immediately after you give the medication. So usually you give benztropine and Benadryl or diphenhydramine, and this you can reduce the dose, discontinue med, or switch. So which common medication do we use that can cause acute dystonia? And we use it for nausea. So metoclopramide or Plasil, I think that's the other name out there, can cause all this. You can see children who are on this sometimes children, they try to avoid it because of acute dystonia. They can have all these eye movements going on. But if you see this happen, you're going to give benztropine and Benadryl. For the exams, you need to know benztropine and Benadryl as part of your. So this will be the last few slides. I have like 4 slides to go. And I want you to concentrate on this. What do you think is the answer? If I can get a poll, Doc, A, B, and C, then we do this. These are the last 5 slides, not more than 5 slides. Then we'll be done for the day. Okay, let's go. 19-year-old woman comes to emergency room with hypokalemia, with alkalosis, enlarged parotids, hypotension, and Russell sign. She has intense fear of gaining weight. She does 2 hours of exercise daily. Excuse me. BMI is 16.2 kg square meters. And what is the diagnosis? Guys, what is the diagnosis?
We have 6 people who voted, 7, 9.
Okay.
Okay.
Give you 20 more seconds. Is that done?
Oh, sorry.
Give them a little bit more time. We are almost done, actually. So.
I may have to relaunch, but.
Okay. One more time, guys. One more time. Just to give everybody a chance. Okay. Seems like most people are not choosing C as the answer. We can stop there, Doc. Thank you so much. We have like 20 people. Thank you. We have 20 people participating, and most of you chose A. Some of you chose B. And I'm here because of some of you chose B. So whenever you have eating disorders, most of the time you're thinking about anorexia nervosa, you're thinking about bulimia. One biggest thing, as much as we have all this information here with Russell sign and all that, the biggest thing you want to look at is the BMI. So the BMI of 16.2, what is the normal BMI? The normal BMI must, usually it's above 18.5 to be specific, up to 24.9, something like that. So that's, if you see somebody who is below the BMI, that's anorexic, whether you think they have some signs of bulimia or not, for the exam purposes, even in real life. So according to the DSM-5, I want to give you some few tips on these diseases. I want you to remember that anorexia nervosa can have the restricting type and the binge eating type, or the purging type. So restricting type is those patients who don't want to eat. They can cook for you. If you are family, they cook for you, they bring food, but they say, you know what, I was eating in the kitchen. They work out like 2 hours, 3 hours every day. And they just know that they are ego-dystonic, syntonic, in the sense that they lose weight, they don't want to eat, they work out. Yeah, it's like it's going the same direction. Everything they do is going in the same direction. Some of them can be the purging type or the binge eating type, whereby they eat. You know, when I was in medical school, I used to be told that this second type is for bulimia only. That's not true. So you can have anorexia. So if you were told that somewhere, or maybe if you misunderstood the lecture, maybe it was DSM-4. So for DSM-5, you have this kind of purging type, and they can come with the Russell sign where they bite them. It's like they have marks from the teeth on their fingers because they want to go all the way back there and induce vomiting. So you can have all those kind of types. And these people are egosyntonic. Like whatever they do is consistent with what they want to achieve. The labs, you do find that you'll get low sodium chloride hypokalemia, hypocholesterolemia. That is a point you should always remember. If you go study, you know, I was just asking myself, why do you expect hypercholesterolemia? You know? So if you read more, you'll find out about the LDL receptors that are not functional. So instead of the cholesterol being taken in, if you remember the metabolism of cholesterol, they remain in the bloodstream. So you see a lot of hypercholesterolemia. There are some theories about it. So they'll have transaminitis. That means the alkaline phosphatase, the ALTs, they'll be increased. They have leukopenia anemia, elevated BUN, because most of the time they are dehydrated. They can use even laxatives, actually, to reduce their weight. Because of the chronic stress they are going through, they have increased cortisol. And GH will be increased, I guess, just to, I'm not sure, I cannot explain the GH why it's increased, but it should be increased. But cortisol, because they're in constant stress, I'll look for the GH, growth hormone, why it's increased. Those are some of the things you will want to know for the exam. For sure, you need to know about reduced gonadotropins, LH and FSH. Remember, their ovaries will be atrophic. So they'll have reduced gonadotropins for sure and reduced estrogen. When you have reduced estrogen, there's one thing you always have to think about: the bones. The bone density will be decreased. They will be osteopenic. And these are patients who can come with a fracture. They work out 2 hours a day and they can come in with a fracture. They can say 17-year-old comes in with a fracture. She has been working out for the last 3-4 hours. Your mind might concentrate on the fracture, but the bigger picture is these are anorexic patients. They can be hypothyroid and hypoglycemic because they don't take enough food. The QT prolongation, so they can have cardiac problems. So what is the best next step for these patients? Send them home on nutritional, you don't want to do that. You don't want to send them home. You want to admit them and start them on. I think I have a slide for that. So before I go to how you treat them, you will have all these complications coming up: cognitive impairment, arrhythmias, QTC prolongation. You have decrease in gray and white matter. They have enlarged ventricles because now the ventricles, the world does not like a vacuum. So because their brain is not developing, they have decreased gray and white matter. The ventricles tends to enlarge. And you have peripheral neuropathy. They have all those because they are nutritionally deficient, lanugo and muscle wasting, amenorrhea and low lipido. So we don't use amenorrhea to really say that that's one of the criteria to get them to be anorexic or anything like that, anorexia nervosa. That is not part of the DSM-5, amenorrhea, because there are many things that can cause amenorrhea. So when you have these patients, as I said, admit them. They will have a lot of fluid shifts with the retention, so be careful when you start the IV fluids. You want to give the electrolytes first: phosphorus, magnesium, calcium, potassium. Actually, potassium is big. I don't have it in my slide. They will be hypokalemic, and that can cause arrhythmias. Or when you give a lot of potassium, that can also cause arrhythmias. So you have to be very careful. They can have seizures. Avoid bupropion. Bupropion increases seizure disorder. We never use bupropion in eating disorders like these ones. And that's a testable question. Replace electrolytes, then slow feeding. You want to start them with slow feeds. You remember, this patient can have this feeding syndrome, and you want to watch out for that. So how do you treat them? After that, in the acute phase, you have stabilized them. You want to go ahead and do a lot of CBT. Anorexia, apparently, it doesn't, if you give them SSRIs, it's not effective for anorexia at all. So that's a good, I'll ask that exam if I'm an examiner, like, what is the management? I give you CBT, I give you some good fluoxetine or something like that. I give you something else like alprazolam or anything like that, and tell you what is the best treatment for these patients. Do CBT. Modley's approach for teenagers, this is whereby like you do a family kind of therapy. You bring family together and try to tell them whenever she cooks, she doesn't eat in the kitchen, she just doesn't want to eat. Then you have supervised weight gain, like you just want to make sure that they are gaining weight appropriately. So the other thing you can give them is pre-meal anxiolytic, just a Xanax, which is alprazolam. You just give them a low dose and just to reduce the anxiety when they eat so that they can eat, not concentrating on. The other thing we do use as a second, another medication we can use is olanzapine. You should know the side effects of olanzapine. Olanzapine increases weight. It can cause hyperglycemia. It can cause diabetes for sure. So if you give olanzapine, in one way, actually they say independently, olanzapine can increase weight. It can make these patients start eating food usually. At the same time, one of the side effects is going to give you some weight to these patients. So this is, I think, one of my last, either the last slide or the second last. So bulimia is usually these patients have normal weight. They are between 18.5 and 24, usually around there, or maybe slightly overweight. Maybe they have a BMI of 25 or 26. They are ego dystonic. Whatever they do, they don't think it's helping them. So for example, they eat a lot, then again, they want to reduce weight, but their weight is within normal. So the medication that have been shown to work is fluoxetine. And fluoxetine is an SSRI. If you remember, fluoxetine is a long-acting SSRI. And there's something about that long-acting, which we can discuss another time. But avoid, as I said, bupropion. Just avoid that. Let's see. Yes, somebody's mentioning bupropion lowers the seizure threshold. Lowers, not increases. That means you can easily get a seizure because it's lower. Okay, I think that should be it.
Okay.
Thank you so much.
There's a question. What's the difference? I don't know if you answered this. What's the difference between bulimia and binge eating in anorexia nervosa?
Oh yeah. So let me say this. Anorexia in can you say that again? Is that in anorexia nervosa or in bulimia?
The question is on anorexia nervosa.
Okay. Perfect. Let me go back there. So the question is, if I got it right, what is the difference between binge eating and
bulimia?
So bulimia is a different. So these are two different things. We have anorexia nervosa and we have bulimia. Most bulimics will be can be binge eating type. You know, they can eat a lot and then they purge. But now this classification is for anorexia to show that you can be anorexic and at the same time you can have features almost similar to, okay, let me put it down here. You can have similar features just like those of bulimia, but you are anorexic because one of your BMI is gonna be low and it's gonna be below 18.5, but you have this binging type of eating whereby you eat and you purge at the same time, but your weight is low, you tend to be more anorexic than you can be bulimic. I know there's that kind of mix in between, but it's good to know most of the time, if you look at DSM-5, they have tried to break it down into these two so that to tell you that as much as we have bulimia, but we can have some people who have features very close to bulimia, but at the same time, they have anorexia because their BMI is low. As I told you, my cut line for these exams is just the BMI. I don't know if I answered your question. I hope I answered it.
But as you speak and people ask questions, we're running a little bit of a poll. It started right now. And the first one is, where are you in your journey to sort of help? And then there'll be like 2 more questions. But if you want to speak, if you raise your hand or on the thing, I can allow you to talk or you can type.
Sure, that will be helpful because I'm not able to get those questions and comments. I think next time I'll be a little bit better in terms of this. I will work with you, Dr. Judy, just to help me out in making sure that I'm up to speed technological wise.
I know that there is, thank you very much. Thank you. There's a question earlier that I answered and dismissed was Bernard Wills. Well, I guess that should be my 4th question. So I'm just gonna close the first question here. And okay, so the first one is, where are you in your journey? And we can share the results here, which is preparing for step 1 is the majority. And medical school. I understand that those are not sort of like, you can be in medical school and preparing for step 1, but I wanted like to get a sense of what's most helpful. I suggested that people type what subjects do you want to learn in future. I meant that you should just enter in the chat or in the Q&A session. So I don't think that was done. And then I think most people have a preference that these sessions be 60 minutes, at least 56%.
60 minutes, yeah.
Yeah, 60 minutes. And then I know someone asked if this anonymous attendee, can we also have 1 or 2 radiology series lectures, perhaps
Oh
teachers
yeah.
radiographs in there, or
So
people
guys,
cover.
if you don't,
But so the question is really, and I'm hoping that some people would like raise their hands to speak or something and unmute themselves. The question is, this was more around, I mean, I learned a lot, but this is still more around gamesmanship, you know, which is how to take this test, which is very commonly trained um, for USMLE, the American medical student. But at the same time, I also realized that we learn this and become better, you know, physicians, and do better on the ward. So if you read like the first aid book, so I guess it would be helpful if we got a sense either through the Q&A and chat, whether people just want to take this format of questions, which I thought was pretty good, or like how would this be helpful for you guys?
oh yeah, that's a very good question.
Okay, I see attendee 1. Give me 1 second if I find who's... Okay, Victor, allowed to talk.
Hello, Dr. Judy and Dr. Walter. Thank you for organizing this. So I think the poll that you just did gives us some sense of direction. The fact that we have 50% of us who are actually preparing for USMLE Step 1. So I think for most of the sessions, we should design them in a way that they can help those students. And at the same time, I feel like the sessions are not going to waste, even to those students who are not planning to do USMLE, because the same concepts that we are able to gain from these talks, we can use them in the wards, no matter where we are going to practice in the future. So I think, yes, there's more to be discussed. And I think I can continue having a conversation with the two of you later on.
Mm-hmm.
Yeah, and see how best we can devise the talks in the future to see how they can benefit a larger group of students.
Awesome. Thanks, Victor.
Thank you.
Anonymous attendee said, I like this as it was. I'm personally more interested in exam prep at this stage because we're not really able to go towards and apply information yet. The exam prep is slightly high on the list in the current moment. And that's true. Victor, is medical school interrupted or resuming later this year?
It's currently interrupted. I don't know if you can hear me.
Yes.
Oh yeah, so far we have been told that we're going back in January. That is the official communication. But for the finalists, for the people who are they're about to finish medical school, the universities are making arrangements for them to complete their studies, but nothing is concrete yet. So as it stands, for anyone who is not a finalist, probably they're at home till January.
Awesome. Okay. I mean, not awesome to be at home, but okay.
Okay.
Okay. Okay. Any other people wanna chime in?
Aditi.
Thank you to Dr. Walter. Really, this is his idea. I'm just here for the tech support.
Yeah. So, yeah. So I don't know if you guys want a class in neurology. I'm doing neurology rotation in the next 1 month, and maybe we can have another discussion if you want. If I don't know how many people, maybe we'll do a poll and see with Dr.
So because the polls don't usually allow you to enter free text, could people type what they want to hear and when? I know, but I think Bernard asked this question, like how frequent. So could you answer at least how frequent it should be? And
yeah.
And Victor, I muted you. Can always unmute yourself just because there's a little bit of background. But could you answer how frequent it should be and what subjects you want to hear next? I know someone invoked me to do a radiology one, which I would be. Okay, so Victor votes for once a month. Okay. So is neurology a good one for the next?
Yes, I think for neurology, most people would love to hear us to have a talk in neurology. I think I would have a lot of audience for that.
Yeah, so there's also neuro, and then once a week, every fortnight, neuro. Could we have the neuro classes with you, and then we can list the topics and books of reference that we could prepare before the classes? So the way, I mean, one thing we can try is, if people are home right now, really, honestly, maybe it doesn't have to be with us, but we can come up with sort of like a virtual learning curriculum. I know this is happening a lot for us right now, where you learn new things that because there's already an interruption, and then have dedicated. So one can be just like a didactic, but then others can be more like this type of high yield material, which I hope Dr. Walter is gonna create a cheat sheet that you can always refer to. Okay.
Sure.
I mean, I don't know if that's, I would think, especially if people are not going to school, that doesn't mean like learning has to stop. So especially areas, I mean, I'm happy to look for people to do like basic sciences type of things. That's just too far away from my ears. I'm old, but could we get a sense of what would you like to hear in terms of lectures? Like, if we got some good people to lecture, I mean, I would be happy to talk about anatomy, but I don't know, are people in fast 1, 2, 3, 4, 5, 6 of their medical school year? Where are people at? Because I can talk about anatomy, but I can use radiology to show you anatomy. Okay, so level 6. And please, if you want to speak, if you just raise your hand, I know Victor is a pro in this. Maybe you can tell people how to raise their hands. I can't find how to unmute everyone so that people can talk. But
So maybe as we're getting other attendees to give their comments, yeah, I would suggest that we follow the units that, or rather the subjects that one is supposed to be good at for the board exams. And we could choose for every month, we could say we'll be tackling 3 subjects or 4 subjects, and for each subject 1 talk a month. And if Dr. Judy and Walter, you can get the speakers for the different units, then that would be good.
Can I speak? I think my general feel for this today is that people really want to learn, want to ask questions, and want to prepare, and they want to go to a certain direction. So if I think I will have a discussion with Dr. Judy on how we can have this structured in the sense that we can have the online like kind of webinars going on, and we can have them structured like neurology. We have a panel that can come in and, you know, prepare something, and we can give you like an update on what we're discussing, maybe on a website or something like that, which we can create. And it will be a diverse, we invite more people on board, we encourage people to continue studying, and I think that will help us not only through the USMLE or board exams, it will help in terms of clinical management of patients on how the thought process should be. I think at the same time we'll like improve the standards of healthcare generally if we have those discussions. And we can, if we have a panel for step 1 and people who want on step 2, we can have suggestions where you can go and log in and, you know, say you want to discuss this topic, and we have a group of people who are interested in it. We can go ahead and organize for that class. It can be weekly depending on how the demand based. It should be driven from how you guys you want it to be done. And we can have like a forum where we can chat and increase things, like have comments and whatever people are doing. so that we have everybody on board, every suggestion on board, and we can keep creating something that can be used for a long time as we keep thinking about it. Maybe that's my thought.
I agree with that.
Yeah.
Okay, one last thing. Has anyone on the group registered for the exam, and could you just put the month? I just want to see, so the people who are preparing.
Good question.